The second issue deals with pathogenesis, clinical description, and epidemiology. There are three types of polioviruses, 1, 2, and 3. So in essence, as opposed to smallpox, where we had to eradicate only a single virus, with polio, we have to eradicate 3 wild viruses. The predominant mode of transmission is person-to-person spread, and it does that in 2 ways. One is oral-to-oral transmission, and that is the predominant mode of transmission in areas with good sanitation and hygiene, and that is particularly industrialized countries like Sweden. Probably the most common mode of transmission is fecal oral. And this is most common in developing countries. And in fact, the virus is shed for a longer period at higher titer in the feces than it is in oral. And with poor sanitation and hygiene, you have transmission of the virus, ingestion of the virus, and then polio. Now, if you look at the clinical spectrum of polio, most of the infections, almost 3/4, have no symptoms whatsoever, totally asymptomatic. So it's very hard to track chains of transmission. About 1/4 of individuals have what's called a minor illness, which is a transient illness, usually of 1 to 3 days of fever, malaise, drowsiness, headache, nausea, vomiting, constipation, and or sore throat. And one would never suspect polio in a person presenting with these symptoms. About 1 in 25, 4%, have aseptic meningitis, which usually starts with a minor illness characterized by fever, sore throat, vomiting, malaise, and then 1 to 2 days later, stiffness of the neck or back with pain in the limbs and neck. These people do not go on to paralysis. And again, unless you know polio is around, you generally wouldn't suspect polio. Paralytic polio occurs in less than 1%. On lameness surveys in Africa in the 1970s and 80s, it was estimated that about 1 in 200 infections lead to actual paralytic illness, and it varies by type. Type 2 is the least neurovirulent. Type 1 is the most neurovirulent. And it's characterized by a minor illness for several days, then a symptom-free period of 1 to 3 days, followed by the rapid onset of flaccid paralysis with fever and progression to a maximum extent of paralysis within a few days. How does it start? The virus enters the mouth and multiplies in tissues with the poliovirus receptor CD155, tonsils, intestinal M cells, Peyer's patches, gut, and lymph nodes. It then enters the blood, and from there rarely into the central nervous system and brain, particularly focused on the spinal cord, although there is a potential from the intestines of retrograde axonal transport. There is a tropism for the nerve and the motor nerves, and particularly the anterior horn cells, which are destroyed. Sensation is normally intact, but what it is you can't tell the muscles what to do because you have that afferent limb that has been lost. And the extent of paralysis depends on the proportionate motor cells that are lost. So again, looking at it before, paralytic poliomyelitis is a very small proportion, less than 1% of it, and of the paralysis, about 85 to 90% is spinal. And that's important because you have respiratory ability then. 10 to 15% have a mixed picture, about less than 1% have bulbar, and that's where you have the deaths from polio. And that's when you have the paralysis of muscles of respiration, and that's the most common cause of death, which is very rare. Characteristics of paralytic poliomyelitis is it's asymmetric, and that's important in the differential diagnosis, and descending. In other words, it goes from the proximal muscles first to the distal muscles. I will never forget my first polio outbreak investigation in 1988, where I saw a woman sitting in a chair, and I asked her to grab my fingers, and it was fine, and to raise my arm, and then she could hardly raise her arm. So it's the proximal first, and there are differences between right and left. There is diminished or complete loss of deep tendon reflexes, but the sensory system is intact. The problem, again, is the efferent limb. And the paralysis, as I showed you, can be bulbar, spinal, or mixed, with spinal being predominant. Paralysis is usually permanent because it destroys the anterior horn cells. There may be some recovery within the first few months, to the extent that there's inflammation, and not. Is there a question? To the extent that there's inflammation, but usually with destruction, you do not get recovery. There may be some recovery from other nerve cells and other muscle sets fulfilling the functions. This is an unreadable slide, but I just want to go over things and you'll be able to see it in more detail in the recording. But the major things dealt. Is there a problem? I hear a lot of voices.
Did we have somebody else join in from some other country?
Yeah.
Okay. Hey, Dr. Thapa.
Hi, Dr. Bhavya. How are you?
Is it the Nepal group?
Yeah, sorry, we got a little bit late because of connection.
No worries. So, the grand rounds has started. We can do the introductions later. Dr. Thapa,
Yes, please.
the Nepal team,
Please, yes.
if you can just mute yourself, and then we can just do the introductions later.
Sure.
Okay.
Okay. So as I said, in this unreadable slide, these are some of the key areas in differential diagnosis of polio. Guillain-Barré syndrome is probably the most common, traumatic neuritis after injection, and transverse myelitis. And what this slide is, and again, I'm not going to go through all of it, and you'll be in the recording where you can see it in more detail, is particularly the differentiation with Guillain-Barré syndrome. And you can see here, fever is critical. Fever, paralysis starts with fever, paralysis ends when the fever goes away, whereas fever is not common with Guillain-Barré syndrome. Flaccid paralysis with polio is descending. With Guillain-Barré syndrome, it's usually ascending. Muscle tone is reduced or absent. In Guillain-Barré, there's usually global hypotonia and globally absent deep tendon reflexes. In polio, it's where the infection sensation is intact. In polio, in Guillain-Barré syndrome, it is not. Cranial nerve involvement is not usually there with spinal involvement. It's often present with Guillain-Barré syndrome. And autonomic dysfunction is very rare in polio, but frequent in Guillain-Barré syndrome. If you do a spinal tap, you will see an inflammatory process in there with lymphocytes predominantly in the CSF. In Guillain-Barré syndrome, you see more protein, you don't see cells much. And bladder dysfunction is rare. And in Guillain-Barré, again, it's more symmetric, whereas the residual effects of polio are primarily asymmetric. So what is the basic epidemiology? In areas where polio has been endemic in the past, the age group usually affected is 6 to 24 months. Young infants are usually protected by maternal antibody. The average death to case ratio is about 5%, 1 in 20. And again, respiratory compromise is the major cause of death. When adults are involved, you have a higher risk of respiratory compromise and a higher risk of death, with some outbreaks, for example, in Cape Verde, having as high as a 21% case fatality ratio. The illness is most infectious immediately before and 1 to 2 weeks after onset of paralysis. And as I said earlier, the shedding is particularly prevalent in the feces, 3 to 6 weeks, and 2 weeks in saliva. And spread is most commonly, in most of the world, spread by the fecal-oral route, although it can spread oral-oral in countries with good hygiene and sanitation. And where this will become important is when we begin talking about the 2 different polio vaccines, which have different impacts, particularly on intestinal immunity. The incubation period from infection, the first onset of symptoms, the first illness, the prodromal illness, is about 3 to 6 days. And from infection to paralysis is usually 1 to 3 weeks, but quite a wide range. The lab diagnosis is usually very good, but it needs to be sent to a good laboratory, an appropriate laboratory, and PCR usually if the specimen is collected within 2 weeks of onset of paralysis and transported appropriately, has about more than 90% sensitivity and 100% specificity. And this is the gold standard for diagnosing and confirming polio. If you suspect a patient who presents with clinically compatible polio, the first thing is to contact public health authorities and collect preliminary clinical and epidemiologic information, including vaccine history and contact with OPV vaccines. Because as you'll see, OPV or oral polio vaccine can rarely cause polio. Collect the samples that are needed. And I want to warn you, because the vast majority of infections are not associated with paralysis, in fact, the great majority have no symptoms whatsoever, you may not get a history of travel to a country that had polio. It may be that there is silent transmission from someone else who traveled. And so if you have a clinically compatible case, you need to consider polio in the differential diagnosis. And a single case demands immediate attention. Now, in a sense, there are 6 polio viruses. There are 3 wild viruses, fortunately named 1, 2, 3, so you don't have to spend a lot of time memorizing them. We've seen a 99% reduction in cases of wild polio virus since 1988. Type 2 was officially declared eradicated with the last case in Aligarh, India in 1999. Type 3 may be eradicated. We have not detected any wild type 3 since November of 2012 in Nigeria. The major remaining problem is type 1. And 2016, we had 37 cases reported. However, oral polio vaccine itself can cause polio. The oral vaccine consists of live attenuated weakened viruses. And it can cause polio in 2 ways. One is something called VAP, V-A-P-P, or vaccine-associated paralytic polio. And prior to our getting type 2 out of the oral vaccine, there were an estimated 300 to 500 cases annually. About a quarter to a third were type 2. The other way that oral vaccine viruses can cause polio is vaccine-derived polioviruses, or VDPVs. And what these are vaccine viruses that get transmitted from susceptible person to susceptible person in areas with low polio immunity, and they mutate and reacquire not only neurovirulence like VAP cases, but they also reacquire the transmissibility properties of wild viruses. So in essence, they're genotypically vaccine viruses, but phenotypically wild polio viruses and cause outbreaks. So in essence, to truly get rid of all polio, we've got to get rid of the 3 wild viruses and the 3 vaccine viruses.